you look at, I think first, post-stroke cognitive impairment is important to know that it occurs in up to half of stroke patients, and it's a major cause of long-term disability and mortality in stroke patients. And if you look at factors that constitute post-stroke cognitive impairment, we can identify characteristics of the acute infarct, size, but also definitely location of the acute infarct, patient-related factors such as age, education, but on the background of pre-existent brain injury. And that's where the white matter hyperintensities come in. So if we look at these white matter hyperintensities, we started our study with looking at the burden of white matter hyperintensities and the effect it has on the different domains of post-stroke cognitive impairments. And if we look at the major domains, we can look at attention and executive functioning, processing speed, language, verbal memory. I think those are the major domains. And if we look at the effect of white matter hyperintensities on these domains, we showed last year that the burden of white matter hyperintensities has an effect on all these domains. So, well, that's, I think, a very relevant finding. We looked at strategic locations for white matter hyperintensities. And what we did is that we looked at several tracts, so white matter tracts, and the volume of white matter hyperintensities within these tracts. And we looked if these were strategic to cognition. And what we mean with strategic locations is that the volume of white matter hyperintensities within these locations is more relevant for the outcome, so post-stroke cognitive impairment or performance across those major domains, than the global burden of white matter hyperintensities. So we looked at these tracts, and what we could identify two strategic tracts, the anterior thalamic radiation at the left side and the forceps major. I think the main conclusion is that strategic lesion location, such as established for acute infarcts, also involves white matter hyperintensities in the setting of stroke. What's important is that we also quantify these pre-existing brain damage, so white matter hyperintensities, both the burden in terms of volume, but also the location, but also other pre-existed vascular damage, such as burden of lacunes, which is also part of small vessel disease burden, and also old chronic infarcts. And I think it's important to look at the added predictive value of these pre-existing damage, the addition to the acute infarct. So, of course, the size and location of the acute infarct is very important for the post-stroke cognitive impairments. But I think prediction can improve maybe by adding these pre-existent damages. And that's actually what I want to look further into.